We're getting started here today with a Compass MS Care program. So our sponsors for the program is EMD Serono, Genentech, Novartis, Sanofi, and TG Therapeutics. Let's give them a round of applause, please. I ask for that because we can't do these programs possibly without the sponsorship of these pharmaceutical organizations to help us to be able to provide this for people to learn around the United States. All right, so today we also had exhibitors from Alexion and Biogen, EMD Serono, Genentech. We had the National MS Society who partners with us to do these programs. We also had Mallinckrodt, Novartis, TG Therapeutics, Vanda Pharmaceuticals. If you don't know Vanda, we hope you had a chance to meet this newer pharmaceutical. And of course, our check-in table. This is Dr. Bianca Weinstock-Guttman. And she is very well known in the area. She's world-renowned MS neurologist. And fortunately, we were able to get her to say yes, that she would present at today's program on a topic that's dear to her, understanding more about aging and multiple sclerosis. She'll speak about treatment options as well. And let's welcome Dr. Weinstock-Guttman. Thank you.
Why do I really want to learn more about aging? So probably you know that a researcher may have their own bias. I'm on this field for 30 years, and I was very much involved 15, 20 years ago to take care of children with MS. Children, unfortunately, may have MS. It was something unknown, and I was very much involved. I have small kids at that time. Now I'm embarking and getting older, and probably it's also a bias, but it's also because a lot of our patients are aging, and I will try to show you, and this is really an unmet need, how to treat and how to make an easier life for our aging patients. So I don't really have any conflict of interest that's related to my talk here. So I will go a little bit over more general MS and aging, try to go to explain why aging with MS is different than early aging. This is why the treatment that we're providing is different. And try to update with what we have and what we're looking for to help treating MS aging. This is a picture that I took it from internet. What I wanted to bring on, and as you know, MS, an autoimmune inflammatory disease, affects the what we're calling central nervous system, brain, spinal cord, and optic nerve. Doesn't affect really the peripheral nerves. And is primarily affected the myelin that is going on. After that, it may affecting the axon, the part of the body of the nerve. But I want to bring your attention on this yellow thing. This is called microglia. There are cells in the brain that are helping to keep up the activity of the brain. And unfortunately, with aging, with chronic disease, including all the aging other diseases than MS, these are becoming activated and produce the disease progression. And this is where we have to get our medication in. So keep in mind, this is our really most important thing. The medication we're getting there, sure enough, preventing is the most important, but we get the point that we have to respond to it. So all the medication we have to try to get this under control, the medication have to be able to go into the brain. And at the moment, we don't have many. So only kind of a short findings of what we have in MS. There are different evaluation, it's called Atlas of MS, that are done by International MS Society Foundation to count all MS patients in the world. It was one in 2013, it was 2.3 million, 2020, 2.8 million, increasing a number. Question why is increasing? It's more new patients. But it appears that it's other reason for we counting. They are including also patients in an area that we thought that there's no MS, that, for example, in Africa. We also diagnosed earlier on. And also what we think about now, and that's again going on aging, is what we say late onset MS. Generally, we know that the disease is onset first symptom between 20 and 50. Before it was 2040. But we know that we have pediatric MS before age of 18. And we do have the late onset MS that is over 50. So we have here in our area increased number of MS patients. We still do not know what the reason we have here. Genetic is possibly part of it. Low vitamin D is, and additional factors. So, going to the aging in MS. The number of aging patients with MS is increasing. Not only here in US, it's all over the world. The truth is, when we're looking on the percentage from all the MS patients in different area, the highest is between 55 and 65, much more than it was before. And part of it is because our patients are living longer. That's not only because we have medication for MS that became available for the last 30 years, but it's also because we're taking care for all what we talked about more, the medical problems, heart problem, hypertension, diabetes, all this, I will show you, interfere really with the disease, and we have a better control now. And as I mentioned before, is the issue on this increased number of late onset. So MS diagnosed after 50 that was not accepted before. This is a nice picture, and only for Canada. Doesn't go here. It was supposed to have a few arrows. This is 1980s. You see the highest number in Canada was around 40s, between 30 and 40s. Here we have over in 2004 and up highest number 60 to 65. So only in one country looking on, things are changing. Here he is, coming, okay. Now this also didn't go through all, is the diagnostic criteria. How to diagnose, and we improve our diagnostic criteria every so few years, and now the most recent ones, we can make the diagnosis at the first visit. Now, sure enough, we have to be sure that we have all the points and mostly MRI-related criteria, but also we have to know that almost 30% of patients on different clinics with specialty for MS were wrong diagnosed. So we have to be as diagnosed as early as possible, but we be also careful because there are misdiagnoses if using only the MRIs. And this is data from our big registry showing that initially it took almost 4 or 5 years from the first symptom to diagnose them, as today we can do it in the same presentation or within 1 year. And that is an interesting one that if you can explain a little bit more on the colors, on the onset. Initially, the highest number of patients were really in between 18 and 30. Look what is now. It's later, it's between 30 and 40. We have increasing number of people over 50. What the reason? So later onset, we still cannot dig in, because if we know, maybe we can prevent this and keep going and not having ever MS. This is a cartoon, kind of complicated, but what I want you to bring attention to is that MS is a continuum. Many of my patients are asking, I'm still relapsing or a secondary progressive? Many of my colleagues trying to say, you know what, we don't want to put a secondary progressive thing because it's patients feel bad. And the truth is that all the medication we have today are already approved for all extent of MS. But what we have to learn is that the disease is changes, and I will go over later on. And that's mostly of the progressing of the disease is going as related to aging. And I will bring it here, the biological aging. We do know that there is a difference between chronologic and biologic. And there is a lot of consideration, not only in MS, but other diseases with chronic inflammation, that eventually the biological aging in MS patients, for example, more specifically, it's a little bit earlier compared with healthy patients that do not have MS and looking for different markers. And I will talk a little bit later about it, how to define biological aging and actually what we can do to make it more closer to the chronological and not to age faster. And as I said, so aging is a primarily interfering factor with whatever happened with changing in the disease pathology and presentation. And what is important to know, and what we talk about, is reserves and recovery. So when we have relapses, we all do, and trying with the steroids and exercise and preventing further relapses. But if it happens, we want and expect the people to get better, back to what it was before. That's not happened. And not happen, especially with aging. In general, the relapses, the number of relapses with aging are going down. There was a study a few years ago showing that every 5 years going on from the first time, you have almost 20% less risk for relapses. And that's good. No one wants to age, but aging have less relapses. Now, not only relapses, they do have less new lesions, less enhancing lesions. These are a few studies. This is a first study including patients in the first 5 years. There was, I'm not sure if a few of them were involved, even on compared to Copaxone or Avonex or combination. And these are the two other studies for secondary progressive. What is found is actually looking for active enhancing lesion in all these 3 studies showing that there are less enhancing active lesion with aging. So aging is protecting for relapses. Aging is protecting from new lesion, but aging is associated with more slow progressive disease. It's a different process. So going back to recovery from relapse, as I said, less relapses. However, the recovery from relapse, meaning going back to what it was before, is less evident than in younger children. This was one of the studies that we did when I was very involved in pediatric, and when we looked on children and adults. The children, and this is the what is trying to compare is going back. What is the consideration to go back how it was before the relapse? So you see that the children are getting much better in all the systems that we evaluate than the adult population. So you have a less risk to have relapses, but the recovery from relapse is less complete as we age. So we're going to the point today that we really think that treating MS progression is actually treating aging. So everyone is in. Now it's all over how to treat aging and all the problems that is coming along with. And sure enough, we have to learn about more what is aging doing to our systems. More than this, as we said, we have in MRI in our patients on aging, we don't see more new lesions. We don't see much enhancing GAD lesion. But what we see are a different type of lesions that are seen only on very more specific sequences in MRI. They are not really seen and used on what we're using in the clinical MRI. It's called smoldering plaques, or PRL. It's a perimagnetic lesions. That what we see is that actually evaluating the yellow thing, the activated microglia around the old lesion. We cannot see them, as I said, in the usual MRI, only with special techniques that is included in the research. Now, looking for correlation, what are this lesion doing, and progression. We do know that this spiral or this lesion with a margin, with a ring that of activated microglia can be seen even very early on, but are less. Increasing the time with the disease progression, and it's seen and proven that more than 4 or 5 of them in the long term, these patients have much more risk to progress. We're learning on, but this lesion lasts very long, almost 5 or 6 years. So we have to prevent them. We have to figure out how to get them down. At the moment, we have no medication that is able to make this lesion disappear. So we're still trying to prevent them, and we'll figure out next. So why is aging changing MS? First is because the MS is related to the immune system, right? It is active and affecting the brain and our central nervous system, is because aging is affecting the immune system. This is always a nice paper with trying to put on all what aging is doing in the immune system, and what is all the immune system aging affecting is not only the brain, affecting the heart, the gut, all the system. So it's a name, I don't like the immunosenescence, but this is what it is. It's aging of the immune system along with aging. So what this means for all of us, it means that there is an increased risk for infection, a reduced risk response to vaccination. We know that for flu vaccine, we're giving a double dosage, right, in people over 60. This is the reason. But interestingly enough, we do have other autoimmune diseases, other inflammatory diseases, as rheumatoid arthritis, myasthenia, sometimes Sjogren disease, other autoimmune diseases that are actually developing much more in aging population. And we do have also non-inflammatory diseases, is what we're calling slowly progressive diseases, as Parkinson, Alzheimer, or other diseases that affects the aging population. And when we're looking on, I said, immunosenescence, but we do have another term that we're calling inflammaging, meaning there is a chronic inflammation that develops in aging population, and these are mostly interfering with diabetes, hypertension, stroke, all this slow inflammatory process going with aging is actually interfering with all the pathology in our aging. So going down, we're trying to help, trying to do research. We're trying very much on it. We have, probably all of you know about the EDSS and our right evaluation from 0 to 10, and that's the best and changing. The problem is when we have aging population having the knee replaced and the hip problem and this problem, how can you really take away and tease out what is MS, what's happening during our studies? So it's an issue. We have to, go through this. And I'm going to what I mentioned before, the other diseases that are increasing in all of us over 60s, and an MS patient too. It's increasing a number after 60 on blood pressure and cholesterol, on diabetes. All these comorbidities actually was seen in previous study that may be increasing even 5 years after the diagnosis. But what we most important is, and I'm really stressing to my patients, all of us have all hypertension, diabetes, we have to take care. But MS patients have to take care even more because it's worsening the MS. If we're seeing that patients have not only one, having 2 or 3 of these the comorbidities, they have a shorter time for the need to use a cane. So all these comorbidities for every one of us have to take care, but even more controlling in MS patient. We saw that also presence of comorbidities, especially the cardiovascular. We had a lot of studies in our MRI showing more atrophy and more pathology on MRI in people that have these comorbidities and not treated. Okay. And going on before also on memory cognition. So as you all know, there are certain considerations even earlier on with specific testing that patients with MS may have more problems multitasking, concentrating, and so on. It's known. Actually, the first time that the evaluation with testing for MS was done by Dr. Jacobs in his Avonex study. However, the testing took 6 hours. I think about any of us going to 6 hours, especially a patient with fatigue. So only 60% of patients really finished the studies, but it was too much. So the newer testing is only 90 minutes, we have 15 minutes, and we have a screening test for only 90 seconds. So using this is much more acceptable, and also seeing and measure to know what are really changes. But what's happening with aging? All of us have these senior moments and coming more. And what about this superimposed on MS already having some slowing and consideration? So many of our patients saying, is this MS? Is this different things? Everyone is concerned of neurodegenerative diseases, Alzheimer's, and so on. So we have testing, and we're able today to really tease out what is really MS and aging. We try to get it better and trying to extend the 90 minutes, but maybe not to go too long. But they require additional, testing to be sure that we are not talking about other diseases, but only MS in aging. And when we're trying to kind of localize, when we have a patient with a lesion, one lesion doesn't really affect, and I'm trying to stress us all the time, patient, one lesion location does not affect a cognition, so on. It's all connection. And also loss of tissue. In the initial stages, what we see first is that this is the central gray matter, it's called thalamus. We see these changes here very much correlated with changing on the multitasking and speed. But what's happening with aging, we do see that the problem is becoming more on the periphery, in the cortical area, that is going on more on loss with aging. But I wanted to bring this one because I really don't have more than 1 or 2 patients from all my thousands of patients I took care that developed other diseases over MS. And this study that I was very happy when it came out from St. Louis, they looked on 100 patients with MS versus 300 control aging. Today, we do have the diagnosis of Alzheimer, and they're coming up the biological markers, the biomarkers. We'll talk a little bit more about this, but it's approved already. It's not 100%, but it is clearly higher chance by having this positive biomarker for Alzheimer to be available and to consider. And what the study showed that MS patients have much less risk to have this positive. So risk for Alzheimer in MS is low, much lower than usual. I know, but the question is what I'm trying to put on, how about the opposite? What is this reason that's a protection for it and maybe help Alzheimer research? Now, what are we doing with? So we have data along for all this. So 30 years ago, we didn't have anything. I was still at this time, and I'm very, very pleased with where we are, but I know we have much more to do. So first, we have to diagnose early. As long as early we diagnosed, we start medication. Never is too late, because when you're looking on this decline, the best is to start as early as diagnosis. So diagnose early, start the medication. That will be much better than no treatment. But it's never too late. Now we have all this medication, almost 30 medication. We're very pleased and so on, and we're trying to do our best. However, all these medication are not mostly beneficial for aging, and I will talk a little bit more further. Not only the efficacy, but it's also safety. So when we have, our discussing with our patient what we're doing in medication, I have, and I know that all my colleagues discussing with all of you what you think, what we know about. Let's put in balance what can we do to be most efficient, but also to be safe. And we know that what we want is maybe not exactly what the patient wants, so we have to put them all together and have a final to be sure that the adherence is good, and we'll be sure that whatever it is will give us an answer for the next month or year. So this was the beginning, right? We started with low efficacy injectable first medication, but they were safe. We're going further now, more and more aggressive, more potent, but that is an issue. As more potent are the medication, they have a much higher risk further on, especially for a long time. And that's what we have to keep in mind. So there are considerations today and data most coming from registries we also have here, but they are very large, good registries in Europe, Sweden, Denmark, the big MS base from Australia. We're also part of it too. That's bring it up thousands and thousands of patients, long follow-ups, and the state and the funding are there. We don't have it here. So what we appears now with having more efficacious medication, that if we start from the beginning with this high, we have in a long time more control on the disease, meaning less disability. The question comes in, how long can we keep on this very strong medication that puts down some of the immune system? And as we see, the immune system further on is going down on its own anyway for aging. So that is a question. Now, there is two ongoing studies, we're also part of it, trying to have what we're calling prospect. The registry is going backwards on see all what happened with your patients. But there are two studies going on from new diagnosis, new start patients, high potency versus anything else. So we'll see what this is showing. But many, as I said, retrospective, this is one of Italian data, already showing, as I said, Sweden, all the other studies was big registries showing that if you start the disease management with high efficacy medication, you have a higher impact on the long term. And these are previous studies looking on the efficacy of medication, kind of what we're calling meta-analysis. It's a little bit an older one. What I found is that the medication have a benefit on relapses pretty much the same, more or less than 50s or 55, but less efficacy on preventing progression if there's over 50. Now, there is a concern because most of the studies now is started to extend. There were very few people over 50. So the number of patients over 50 was very low, none of over 55. So the data on what we treat and how to treat is coming only what we're calling from registries, where we have additional data, but not into the real strong clinical trials. So the issue is we're trying to get more information, again, that is, open life, real life data on the registries to find out how all the medication we have out are performing in our patient aging population. And the problem is, as I said, when we have already an more immunosenescence, etc., already a more suppressed immune system, we do have a more concern on safety. And more concern on safety on cancer, as cancer is going up for all of us over 50, you have a medication that puts down even more immune system, it's really a concern. Same is for the other laboratory tests, especially the immune cells that protects us for infections. And that is also a concern. So all the time we have to think about imbalance, efficacy versus safety. And many patients also with studies showing that have a comorbidity. We have some increase in blood pressure, some increase in cholesterol during this medication. So we have to be sure that this is really going on and we're controlling on this. So what we do, what should we do? There are a lot of questions about if a patient aging is already in high efficacy medication, we can go for a while, but we have to think about de-escalation or de-risking as it's now on. So what we do is stop, we increase the time in between, decrease the dose. Still, we're so not sure. The most of the time depends on each patient, the disease activity on it, because you may have surprises being still active in elderly, or stop. Now, the other medication, including the injection, is the question, should we stop? Should we continue? At least the continuation is not a concern from safety. But the question is the cost, and the question if it's doing anything. So, with all this in mind, there was a big study, paid a lot, millions of dollars for a PCORI study, tried to stop medication in people over 55. They didn't have any relapse for the last 5 years, no MRI new lesion for the last 3 years. There were 300 patients divided 150 and 150. 150 continued the medication, 150 stopped the medication. A new comparison between the two from a research standpoint is called non-inferiority. So to be the same. The patient was followed for 2 years, and the primary thing that they're looking for is to look on relapses, new lesions, and progression. The new lesion and the relapses were put together as events, and there were more events in stopping the medication, and that's mostly related to MRIs. There are not many. The MRI lesion on the patient with MRI new spots were not related to relapses and no relation to progression. So the conclusion is go back, talk to your patient, and discuss what should be. Most of the patients were in the early 60s. And most of the patients were also on the injectable. Part of them were also, though, on high efficacy medication, including natalizumab or oral medication. Part of them is probably, you know, that natalizumab on oral medication, sometimes when you stop, you may have the MRI reactivation. Now, looking on, this is a study from our big registry looking on, the slope going on is faster. We did see that patient discontinued the medication had the faster, but these were patient all ages. And maintaining the medication or starting medication was better. Interestingly enough, and that wasn't only our registry, they're also supported, but less and less in the legacy, as we're calling registry. When the patient came in on our registry, when Dr. Jacob started in 96, many of them were long disease duration and no medication. So they decided not to go on any medication, and they did the best. Now, we don't have the possibility at the moment of the diagnosis to know who and how these patients are. There are a lot of consideration. The benign MS doesn't exist, especially that these patients were not really evaluated much with Memory-Cognition. Most of this evaluation is walking, and this is how EDSS. So, but still, even Dr. Jacob said that he knows that he will overtreat 10% of patients, but it takes the risk. This is another study from ours that we looked on patients from our registry before and after discontinuing, different reason for discontinuation. Having 70% of these patients before discontinuing for 2 years were stable. After discontinuing, 1/3 of them worsen. Now, these patients were different ages. Only 20% of them were really over 60. It's again, the retrospective has its own limitation, but really raised the consideration, and it's all the time cited in all the studies and all the papers. There is a concern that we still you're not able to really measure, say, you can stop, you don't. There are studies in Europe, they try to stop at 50s. Most of these people were on high active medication, and they had to stop the study because they have active MRI. Not so much relapses, but active MRI, especially if the patients were on very active medication. Okay, so going to what we can do and use. So metformin. So metformin, everyone knows about using it for prediabetes or diabetes, decreasing the glucose, but becoming also known, I don't know if you read about any kind of anti-aging intervention, metformin is one of them. Metformin is considered as what we saying to my patient, the holy grail for aging, having much more effective effects besides decreasing the glucose. And that is an antioxidant, also providing protection of the mitochondria. And there are also considerations that may help on repair. There is an ongoing study with metformin in Toronto, Canada, where my previous fellow, that's a pediatric neurologist taking care of children with MS, with metformin in children with MS as an add-on to their medication. This is a nice cartoon and trying to figure out where really the metformin is working, but primarily in animal, and the little flies did show that clearly increased longevity. Now, it's where it's working, as I said, on the mitochondria, the energy side of the cells. And this is an interesting thing, that's what I mentioned before with biological aging. It's, you see, the end of the chromosome is called telomere. The telomeres going down with aging. So this is one of the ways that we're measuring the biological aging, and this is how it was found in MS, it is lower. Interestingly, metformin may hold on losing it. And I don't know if you know also, I kind of jumping all the time, as my people know about. But most recent, the vitamin D was shown that can do this too. Vitamin D, especially in patients with chronic inflammatory disease. So take vitamin D. Okay. And that is what a small data that we looked on our patients that received metformin as medical need with metabolic syndrome, pre-diabetes. They were all in their 60s. We have over 20 in each group. We had a group that had the metformin, a group that had the metabolic syndrome, did not have the metformin, and another group with the same age and characteristic, but no metabolic syndrome, the obesity and so on, that clearly also interfere with the disease. And the winner is really metformin, and metformin with the lowest maintained the disability EDSS. So I only showed a little bit, a lot of researchers in Europe put all the data that is in metformin, and they are considering, and is ongoing, ready to start, metformin study for patients with progressive disease. They do not have any other medication approved at the same time. So they have to be off medication, being considered progressive, and trying metformin. So it's Europe, and meaning UK and Australia. Now we have a small study here. It will be only for 1 year. We have only 30 patients, part of the university through their NIH grants. And because it's only 1 year, we won't be able to see real changes on the exam. We're using very sophisticated MRI and try to see if this will be changing. Will be only 15 and 15 patients. And also we try to look at biomarkers, what the blood tests that we know about that can really have more information on what metformin can do within 1 year. Now, the many studies supported by the MS societies, internationals, and this is what is from UK, had already previous study trying to make it more cheaper. So try by decreasing the amount of money put it on in the study versus the pharma is to have 2 or 3 different active intervention. So the study on metformin in UK and Australia for progressive patient has another arm that is also active. It's called lipoic acid. Probably you heard about the lipoic acid. It's a fatty acid. It's having also antioxidant benefits. And it's mostly known that benefit patients with peripheral neuropathy and diabetes for pain. But it appears that may have also a small study in MS that decreased the risk for brain atrophy, an antioxidant. And what is the most important also for metformin and lipoic acid, they are able to go into the brain. So penetrate the blood-brain barrier. So they're able to go where it should be. And the study is going on. That could be, the lipoic acid is produced in the body anyway, but it's going down with aging. So this is why it's maybe good to add on. And let's talk about what is much more, studies going on for progressive patients, and that is the BTK, proton tyrosine kinase. So we're thinking about always we're using the most efficient therapies with the B-cell therapy that destroy the B-cells. Now the question is, how long can we hold on this? The B-cell therapy was what we know all, that's Ocrevus and Kesimpta, and they are not able to get into the brain. So they are working only in periphery. This, small molecules benefited also the B cells, but they're only that they're not destroying them. So they are not decreasing the production of good antibodies and so on. They're only turning off all the factors that go and activate it to inflammation. So it appears that can be, and they are able to go into the brain. So there are all this mechanistic positive consideration that we expect this very much to be able, when available, to use in patients with progressive disease and eventually de-escalating or changing from the long-term Ocrevus or all the other B-cell therapy that are long-term, and already we see the decrease in the proteins, the immunoglobulins going on the risky levels. As I said, they're able to go into the brain, affecting the B cells, but also affecting the yellow one, the macrophages and the microglia. So that is the good part. It's not only towards the B cells, so much more broader with consideration that have more efficacy. The problem is that we have many of the products. Every company has its own. None of yet approved FDA. The first one that was evobrutinib did not show. What is happening with this medication is that everyone is trying to prove that there are also anti-inflammatory effects, and they have, but they are not very strong. So compared with the teriflunomide, or Biogen, that many probably of you didn't show any benefit on relapses and on the MRI activity. But really the issue, what we are looking for on BTK, at least what we're looking and what the additional next, compounds are patients with no relapses, no new lesions, but progression, preventing the progression. So the next to come is tolebrutinib. They already published data on the relapses that indeed the same thing with the teriflunomide. But interestingly, we have to know when you read or you discuss this, the patients in the two groups comparing were very, very low relapses. Meaning what we're talking about, the benefit on teriflunomide for long time on the Biogen, they did have one relapse. They were let's say I don't want to a number, there's 0.3, 0.4, all of them 0.1. So one relapse every 10 years. So the type of the patients that are going in the studies were also influencing the results. But the tolebrutinib, the second study on non-active MS, no relapses, but no new lesions and progression versus placebo, did show benefit on preventing progression. And we'll see further on. The only problem, that's actually a problem, all of them may affect more the liver function. There are almost up to 5% of patients that have really up to 5%, 5 times more the liver function. They mostly start in the early stages, have to be followed. They are recovering, but that is the primary concern on this BTKs that we are waiting for. The CAR T cells, they are very engineered T cells that will go and specifically to go and decrease the B cells. They are able to go into the brain. They require chemo before, strong chemo, some complication after providing this treatment, but it may appear able to go into the brain. But there will be for only patients very active. They had very good benefit on cancer. They're also used a lot, and that is primarily in lupus, other autoimmune disorders. And there is also ongoing study for MS progressive. And this one, the foralimab, we're waiting on. I need patients for this. This is a medication. There's still phase 2 trial. It's a nasal spray. They are not immunosuppressive. The only side effect that eventually may irritate the nose, because this is how we're given. There are 3 months treatment with 3 times per week for 3 weeks, 1 week off for 3 months. The product was developed in Harvard. They had data for 6 months and more extended studies, and they're looking now for more center to try to use it for patients, again, that did not have relapses, they do not have an MRI with new lesions progressing and with no medication on board. I don't know if you see this. I don't. Do you see the yellow things? So not very good. But anyway, that was data on these patients with PET scan. PET scan can actually measure the yellow things, the microglia activation. And that's, we can clearly see after 3 months decreasing, and that actually even the treatment is 3 months, you can see benefit even at 6 months. And that is the same thing. So really supporting the what is expected from. And I will finish my talk with going back to Gretchen, what he said. The medication are very good, but we have to work much more than this, and that is brain health. And the brain health is going with exercise, taking out all the negative factor, including smoking, too much alcohol, and exercise. And all of these are very important also for people young. We have to maintain and maybe extending the reserves. The reserves can be, developed or always grow and adolescents and so on, but they can do a lot of difference between 40 and 60s. Why do we see they saying, I'm very much, I told you about an aging. The aging is not going down, same on. We have a drop at 40, and we have a drop of 60. Now, sure enough, hormones and whatever other things are, but there are certain things that we can do between 40s and 50s, I passed it, but increase, and anytime it's not too late, to try to prevent the reserve. Why do we need the reserve? The reserves are able to actually help on buffering and overcoming problems related to injury. This is why in aging, we don't have too much lesion if we're talking about other disease, after lesion and so on, but we do have a decrease in reserves. So older lesions are becoming more evident there because the compensatory mechanisms are down less. So we have to keep them up. And what, again, we saw, I said, other studies before, the comorbidities, but the lifestyle, people having a better diet, good sleep, all this, what we saw, maintain a better MRIs in our data. And I'll finish, this will be my last one. There are studies on exercise. They are very expensive in order to prove the benefit on MRI, using PET scan, MR, functional MRIs, all kind of very expensive. They cannot get more than 3 months of intervention, but they are able to see a difference within 3 months of exercise. Cognitive rehabilitation was a very large study, finished so-called because they tried different intervention. None of them were really placebo. Everyone did good, better. But what I wanted to tell you about is that really you can see a change. You can see a change on the functional, on the connection in the brain within 3 months. More than this, what we also see are biomarkers. I won't put much on it, but that's what is our hope, that we can learn more and monitor more what's going on in the brain without MRIs. And these biomarkers, probably you heard about the serum NFL, the GFAP, all these biomarkers are showing that may pick up what's going on the brain and can be used, but should be used repeatedly. They are approved in New York later than other states, but the insurances are not paying yet. We're trying to figure it out and try to get this, approved. There are other studies that's called OCTAV that are trying to identify it and correlate with active MRIs. Again, approved. We have to figure out further on how to have this done and how the insurances can pay. May decrease the need for the MRIs and may help us to see what's going on and monitor better on the outcome of the disease. And sure enough, us as practitioners have to know and to push and not to have only a pill. The pill is doing, as I said, we're struggling, trying to be sure that we help and not damage or so on. But it's very important really to reemphasize the importance of exercise and good sleep. You probably know, everyone, yeah, sleep is good. But sleep is really, at the moment, clearly proven that it's the only way to improve all the waste to be eliminated. You probably heard about this, lymphatics, right? The brain, that's a way to eliminate the waste. The lymphatics, that is also so-called prevented Alzheimer, all the ways go, it's going up 3 to 6 times during sleep. So a good sleep hygiene is very, very important. Besides that, you'll feel refreshed and so on. So we have to have time, us as practitioners, to put on this. In conclusion, again, we have the taking care of aging in MS is really an unmet need. We need the highest number of it, and we have to improve our measures. We have to improve, measure clinical images and hopefully biomarkers to be able to monitor how our patients are doing. So this is our team, Dr. Eckert, Dr. Henaki, and Beth, our nurse practitioner, the Buffalo group, and our neuro-ophthalmology, the neuropsychology, our lab, and sure, our own Penny Pennington, that is director of our development and management. Thank you.
What is the most recent update on remyelination?
Oh, yeah. So I was all the time talking yesterday, 2 days ago with Penny on this remyelination. Meaning we really want to have, and probably it's very important to have the possibility of repair remyelination because this can keep the nerve, the axon alive. But we need to have the axon there. So the problem when we have the more progressive disease, we don't have on what to myelinate. So the intervention that we'll have to remyelinate is really, again, back to very early on, if we'll be able to do. We have a lot of studies done primarily on the little mice and rats. And actually, we have a very nice study done in rabbits, because that was a question, is really the brain size different? And this is why we have so good effects on the little ones and not in human. So that was done by one of a UB researcher, Dr. Sim Fraser, with a MD PhD, was recently published in Annals, tried to determine the effect, size, location, didn't see much difference. But when they looked on the one that was the future on the remyelination, the clemastine, not only they didn't see benefit, it's actually concerning. That may decrease actually the support of the new pre-oligo. So there are a lot of studies, there are a lot of energy for researchers to go on. As I see this, that this will be, if will be available, have to be added on very early on. And I hope that this will go. But at the moment, I am much more towards neuroprotection, preventing the inflammation we have so much, but a neuroprotection of the tissue, what we have, what to do the best, because I think it's the most low-hanging fruit. Sure, we should go further, much more.
What do we do? What's being done to raise the clinical trial age status?
Yeah, so that's going up. So many of the studies now, we have up to 75. So we knew the problem now. As the studies are going now, though, towards progression and preventing progression, are really including, the inclusion criteria is much more extended, and it's going. The issue on the new, early, more inflammatory stages, that also may go probably on 65 or so. Although, as I said, having the studies, we want to have a lot of information. But beginning on, we didn't differentiate anyone. We put everyone together, nothing was positive. So in one side, as we're learning now that the disease is different, it can be a difference. So we have to be very, clear. And even if it's not fair not to be able patients to get involved in the study, we have to have a better results. But yes, for the progressive patients, we have 65. The Foralumab is going on for 75. For active, as I said, new start patient, new ongoing, onset after 50, they'll be probably much more involved now, 55 or 65, as new relapsing patients, yeah.
Thank you. So going forward with that, people want to know, how will they exclude or how will they include comorbidities into these trials?
You're absolutely right. The studies are usually cherry-picked to take the best patients with no other problems. But in general, there is no contraindications, but the disease has to be controlled. So if you have diabetes, you should have diabetes well controlled. No change on medication recently. Same with the blood pressure. The blood pressure should be controlled on medication. So it's not usually an exclusionary criteria today.
Thank you. Question here?
Do you think that tinnitus can be caused by MS?
Ooh, yeah. Tinnitus is usually, we have some patients that had an acute hearing loss and after that tinnitus. The hearing loss sometimes got better. It's rare to be an acute event, but usually it's rare and not related.
And vitamin D, is there such a thing as too much?
So nothing too much is even a good thing, right? It's too much is not good. So the vitamin D has, what we're looking on the lab, up to 100. There were certain studies that showing that over 60 and 70, over 60 may affect may increase the risk to have heart disease. The other study could not support this, But there is a concern that if it's too much vitamin D, can go and be deposited because the vitamin D is increasing the calcium, and the calcium can go in the places that we don't want to, especially in the vessels and especially in kidney. So there is a consideration that the recommendation is to have between 40 and 60s. Above 60s is not good. So decrease the vitamin D supplementation, whatever you're taking. And what I'm saying also, check the vitamins. Don't take the vitamin in the morning you're going to check it. And second, try to use the same brand. Don't move around.
My question is about the PRL lesions. It's really the first time in the last month that I've heard of those. Is that something that's been recently discovered in the last 5 years?
Yeah. The perimagnetic lesions, as I said, are picked up with different sequences, SWI and so on. You see it's iron over there, and there's like activated microglia. It appears, as I said, it was described probably 6 or 7 years ago, starting to be reproduced in different research. It is able, if the sequence is there, it can be analyzed, can be seen on the open eye so much. So it really requires a better analysis. Clearly was seen that could be seen, unfortunately, even early in the diagnosis, is going up with aging and disease duration. And it's showing that you have more than 4, even early on, and having follow-up, it was associated with more significant decline, so more aggressive disease.
Question in the back of the room?
Yes, some very inspiring information for us, Dr. Guttman. You mentioned R-alpha-lipoic acid. Could you give some additional information on where a patient should get it? Is this something they should discuss with their MS specialty provider?
Yeah, I do think that, it's not, it's a supplement. Many patients taking a lot of supplements. That is one of them. I do recommend to my patient giving the chance to do it and try to follow it. We do know that it's only 30% absorbed. There are different type of it. If there doesn't, nothing is in before the lipoic acid, it's probably combination of the chemical, it's racemic, the R and the S. What is indicating that in order to improve absorption and outcome, get only the R in front of it. The primary downside is may affect, a little bit the GI and the way how you feel a bit bloating and so on. If you start low, usually it's considered to be on empty stomach, but if you cannot take it with food, and after then very slow to go up, the dosage for this is maximum in the study is 1,200, usually starting with 300 twice.
Thank you. Next question from online. Person writes, for those that are using wheelchairs or mobility scooters, regarding weight loss issues or having weight loss problem, needing to get weight loss, what is recommended since exercise is very difficult?
So you have a lot of patients that are trying to, first of all, overweight is not good. There's no question about bringing up the blood pressure and other comorbidities. Watching what you're eating, it's important. Try to exercise, what Gretchen is saying. Going towards the possibility to use the weight loss medication, the GLP-1, we are not able to recommend this. Only the primary, and especially if they're very high weight, really over 30 BMI or so, and you have additional comorbidities, sure enough, the primary will go. We're trying to go back on our patients. Some of our patients tolerate very well all the combination, or Ozempic, or all the Zepbound, or the other ones. I don't want to get into it because there are side effects from it. So this has to be very much overseen by an endocrinologist, by the primary, followed. The slowing down on the stomach and constipation that may be already in MS patients may worsen. So needs really hands on it, plus the previous data more on visual problems with non-arthritic ischemic optic neuropathy, or even now coming up with macular degeneration related to it. So there are concerns. It's true too that most of what you read are the concerns, and you may not see the benefit in patients. There are patients that see really benefit by using, lost a lot of weight, able to maintain this. So as I said, what you read mostly and so on is the bad stuff. But you have to keep in mind that it's not so benign. So I do believe it in the end is probably good. There are some people, I have a patient that lost a lot, looked great, doing very well, and now she's micromanaging, doing with half dosage and so on. You probably heard about this. So everyone is doing what they want. And also may have this prescription got from whoever got, not prescription. I'm not for it at all. So you never know if it's really, was a compound, was this real, what it is on this. So I think that this has to be, I don't say no. I think that it could be helpful, especially that now, especially for Ozempic, it's going up, try to replicate what metformin is doing. So show benefit on preventing heart disease, show benefit on cognition and Alzheimer. So all this benefit that we're calling pleiotropic, so extra than the glucose for metformin, everything they are trying to show that was seen also with Ozempic, that it's the longest time on the market. Cancer, you know that metformin is in diabetes, decreased risk for cancer. So all of them is now you see and read that Ozempic is doing the same thing. So probably will be a good thing, but has to be controlled.
Thank you. Next question is about person asking, saying that they've heard a lot about that there's many people with headaches and migraine with MS, and what can be done to prevent not just headache migraine, but ocular migraine.
Okay, so I'm not a headache specialist, but yeah, MS patients have more headaches. Which type of migraine? There are a lot of new treatment. There are injection, Botox, and all this thing, preventive medication. They are breakthrough medication. So yeah, why MS patients have more headaches? Not sure. We had a one-time study showing that patients with headache have more enhancing lesion. Old studies, but altogether there are a lot of headache specialists today, and can be tried new medication that also preventive medication, and also especially preventive medication and injection and oral and so on. Expensive, has to be fought to get approval, and mostly, the headache specialist can do trigger points and so on. So there is a lot on it.
As you know, most of the patients with MS are female. Perimenopause seems to be, give it to the gynecologist. The gynecologists are going, that just happens. You have night sweats. But it seems that the symptoms are progressing. So can't we get together and work both sides instead of one side going, talk to your gyno, the gyno going, well, live with it. But it clearly is impacting more than half of the population. And so this is a big concern that I have. How can you address that, please?
Okay, so there is actually a lot of interest and studies on menopause and MS. And we know that menopause, it's going back to my stack of aging, is part of it. Hormonal is part of it. Why changes? But altogether, doesn't appear, only one study did show that maybe you do have some decrease in the physical part, but altogether it's more symptoms. And as you said, is the hot flashes with increasing temperature, worsening on it, and that's a problem. That symptom can get worse, not so much the disease itself, but if you don't able to exercise, it may affect in general. So the gynecologists, at least in our area, they're pretty much on it, but I am also part of it. Sure enough, anything that it was before the HRTs, no HRTs, and I mean hormonal replacement therapy, bad for side effects, for heart disease and so on. It's coming back, especially between 50 to 60s, that maybe in low dosage, maybe not really concerning and maybe help, especially for the hot flashes. And that's more gynecologists are aware about and controlling this and trying this. Now, sure enough, additional intervention for the hot flashes, we have all this old black cohosh and primrose oil. We had also one of our colleagues that is very much involved wasn't hot flashes, and it was gabapentin. Some patients with hot flash with MS and hot flash in general responding with evening gabapentin. Not everyone. So that's what's also symptomatic medication to try to help on it. So what is my concern primarily menopause, as I said, with no clear cut that this is worsening, is to try to help our patients for the hot flashes. What I'm raising primarily is also bones. The osteoporosis that we see in MS patient is worsened within 3 to 4 years after menopause. So very much into it. If it wasn't done by gynecologists, we requested to do it and monitor, including the exercise, also preventing the bone loss, but that is one that also we're watching, and we do. I know other practitioners, but we're very much trying to discuss if the patient had any other risk factors, and still the gynecologists want to start on low hormonal therapy. It's fine. We communicate with in between and try to figure out and help our patient.
Great, thank you. Next question. MS patient writes, I have a family member with Alzheimer's, and I'd like to know if that's something that should be of concern to me as well.
So yeah, I do have this concern, especially that our patients have aging and have this. So my number of patients very, very low. I cannot say completely zero. I've proven that here the data that based on the biological marker that the risk is low. Sure enough, if you have someone with a genetic part but it's not enough. So we know we have an Alzheimer control there. If I wouldn't really consider unless the patient has any form, but there's nothing preventive at the moment. But if they have more study and wants to be part of the study, we do have this SMS part and also, Alzheimer research in our clinic.
Thank you. Before I continue here, anybody here have a question? Okay, I'll be there in a moment. Next one writes, going back to the memory issues, is there a specific medication that they can use is there something available now that they can use to help with their memory?
No, at the moment we don't have specific for the MS memory. We had before a study with the Adderall type. We called Vyvanse, that we showed a little bit improved in processing speed and so on. If it's approved and there's no other concerns on blood pressure problems and so on, we may give a small amount, but really we don't have any preventive medication for it. We do think that maybe, as I said, cognitive improvement and maintaining really improvement is coming up with exercise, and is coming up with good sleep and with clearly diet and so on. So I think that all this brain health wellness things is very important without really at the moment any medication we have.
Thank you.
Hi, Dr. Guttman. Now, I know you've answered this question several times, but I'm going to ask again. One of the side effects of MS is the fatigue. I mean, that's the elephant in the room. And I know what you're going to say. You're going to say exercise and good rest and diet. I know. But is there any kind of pharmaceutical aid that can be given so people aren't using off the shelf, like caffeine pills or, stuff like that. Are any of the MS medicines target that fatigue, or is it a side effect of most of the medications?
So fatigue symptom that is the most frequent in MS has a lot of causes. So it's hard to really go probably at the core how to treat. First of all, we need to have a good sleep, and that's generally we want 7 to 8 hours. Some people saying that they are okay, that are up to 6 hours. That is all genetically clocked on, but also too much sleep is not good. And the medication, some patients, like to Provigil. Some patients see the benefit from also for fatigue. That's as I said, Adderall and all the supplements. But when was the amantadine, and my patients are, absolutely saying this helps. But the study, now again, all the studies are not 100%, but as you probably know, the study with Provigil, the amantadine and the Adderall, it was the same as the pill, the placebo pill. And it was a lot of $1 million done by Picori study that is paid, study money for other studies that could go for other. So I cannot rule out that patients have a really increased sleepiness, and maybe for them, Provigil can help. Many patients of ours have sleep apnea, so their sleep have to be really, improved by using different masks. So there are a lot of the consideration, and more, I would say, in the wellness type than trying medication. And that's what I can say. That's what I know. I know that fatigue it's a concern, and you see that the patient is more or less you're doing. It's probably Gretchen is here also the same. You're becoming again more fatigued. So it's kind of a vicious circle.
Thank you. Next question is from a person who wants to know what's available for those with secondary progressive MS.
So I thought that my talk was all about. So if the secondary progressive, there are still relapses that are going on for everything we have. All what we have, 26 medication, are good for people that still relapses active disease. For patients that are no relapses and progressive, that's the question, are still on medication or no medication? And that is where we're going towards the newer intervention. There are studies going on. We don't have something yet approved for what we're saying non-relapsing disease. Although the secondary progressives, they said active secondary progressive, all the medication we have today is for it.
Thank you. All right. I want you all to have a very safe day, and thank you for coming. And everybody online, thank you as well. Bye-bye.